Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observation and commentary on the JCO article, Access to Accredited Cancer Hospitals Within Federal Exchange Plans Under the Affordable Care Act, by Kenneth L. Kell et al. My name is Stacie Dusetzina, and I am an Assistant Professor of Pharmacy and Public Health at the University of North Carolina in Chapel Hill, North Carolina. I'm a PhD-trained health services researcher whose work focuses on access to care for patients with cancer. Access to timely and high-quality cancer care is critical for patients facing cancer. Many cancer-directed services are obtained in hospital settings. As such, having access to hospitals and physicians with expertise in cancer care delivery is important. In the U.S., hospitals may receive accreditation from the American College of Surgeons Commission on Cancer, which represents their meeting standards set for cancer care-related measures. These include having multidisciplinary cancer committees, cancer registry procedures, and availability of or referral to clinical trials. Among the 1,455 Commission on Cancer accredited hospitals in the U.S., 62 are further designated as National Cancer Institute designated cancer centers, those that participate in cancer-related research in addition to clinical activities. Importantly, some research shows that receiving treatment at these centers may improve outcomes for patients with cancer. The study by Kell and colleagues, Access to Accredited Cancer Hospitals Within Federal Exchange Plans Under the Affordable Care Act, addresses an important issue related to patient access to both Commission on Cancer accredited hospitals and NCI-designated cancer centers. Specifically, they evaluate whether these important centers are included in-network on health insurance plans offered under the federal exchange. To understand the impact of these findings, it is important to consider what being in-network might mean for a patient who is seeking cancer-related care. As part of the Affordable Care Act, beginning in 2014, many individuals enrolled into commercial health insurance plans offered on the federal exchange. These plans are available to individuals who do not have another credible source of health insurance, such as an employer-sponsored insurance, Medicaid, or Medicare. According to a report from the Kaiser Family Foundation, over 11 million individuals were enrolled in either state-run or federal exchange plans by 2016. All of these plans theoretically protect patients from catastrophic spending by including an annual out-of-pocket maximum. In 2017, these limits are $7,150 for an individual and $14,300 for a family before subsidies. However, plans are only required to consider out-of-pocket spending for care received in-network. If a patient receives services outside of their plan's network of providers, they may be responsible for the full cost of those services, regardless of whether they have met their out-of-pocket maximum. Given the potential benefits to patients for having access to both Commission on Cancer accredited hospitals and NCI-designated cancer centers when undergoing cancer-related care, it's important to understand whether these institutions are accessible and in-network for federal exchange plan enrollees. In the current issue of the journal, Kell and colleagues explore this issue. They found that 95% of the unique provider networks within the federal exchange plans contained at least one Commission on Cancer accredited hospital, suggesting that most patients would have health plan coverage for services received at these centers. However, of the 37 states offering federal exchange plans, only 31 states had a Commission on Cancer accredited hospital located within the state, which may signal access to care problems independent of insurance coverage. Next, they evaluated network access to NCI-designated cancer centers and determined that only 41% of all provider networks available within the federal exchange plans included one of these centers. Interestingly, and perhaps not surprisingly, networks within states that included an NCI-designated cancer center were more likely to include those centers. but coverage was still only provided for 44% of federal exchange networks in those states, versus 18% in states without an NCI-designated cancer center. Similar findings were observed when the authors looked at provider networks in counties with and without NCI-designated cancer centers. Most consumers shop for benefits based on monthly out-of-pocket premium payments, represented by metal tiers on the exchange: bronze, silver, gold, and platinum. Interestingly, there was no association by plan metal tier and access to Commission on Cancer accredited hospitals. Most consumers shop for benefits based on monthly out-of-pocket premium payments, represented by metal tiers on the exchange: bronze, silver, gold, and platinum. Interestingly, there was no association by plan metal tier and access to Commission on Cancer accredited hospitals or NCI-designated cancer centers. Instead of representing network coverage, these tiers typically represent various levels of premiums and out-of-pocket costs to the patient. What does this mean for patients with cancer who are seeking care? First, for patients on the federal exchange, access to an NCI-designated cancer center may be limited, even for people in counties or states that contain such centers. Second, consumers shopping on the exchange may need to carefully consider whether their selected plan has network coverage for their preferred healthcare provider or hospital within their area, including access to Commission on Cancer and NCI-designated cancer centers. Third, metal tier is not a good marker of network access. This may be easily mistaken by consumers who assume that paying a higher premium could indicate that they have better access to services and providers. Unfortunately, patients may not fully understand the impact of narrow networks until they need cancer-related care or receive out-of-network services. In these cases, patients may be subject to very high out-of-pocket costs that add to the burden of undergoing cancer treatment. These costs include having to spend above the expected out-of-pocket maximums, paying the full cost of care for out-of-network services, and not having coverage for standard of care costs for participating clinical trials. These charges can expose patients to incredibly high spending and risk for financial catastrophe, not to mention the distress associated with high medical bills and outstanding medical debt. Although the future of federal exchange plans is uncertain, ensuring patients have adequate access to and coverage for cancer-directed care is important for minimizing financial toxicity and improving patient outcomes. As insurance markets consolidate further, network coverage may become a pressing issue for all commercially insured patients, regardless of their source of coverage. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.